for this award to the Senate's Committee on Research, and I'd like to thank the committee for their hard work in reviewing the nominations and selecting this year's awardee. Today, we're proud to honor our colleague, Dr. Kathryn Phillips. And now I'm pleased to introduce one of Dr. Phillips' nominators, Dr. Joanne Spetz, a professor from the School of Medicine. She is the director and Brenda and Jeffrey L. Kang Presidential Chair in Healthcare Financing at the Philip R. Lee Institute for Health Policy Studies here at UCSF. And she also directs the federally funded UCSF Health Workforce Research Center on Long-Term Care. And now I'd like to welcome Dr. Spetz to give her introduction. Thank you.
Lowering that microphone for the height challenged. Well, it is a pleasure to be here today. And I need to figure out how to advance the slides now. Just the arrow. There we go. Makes it easy. So I was really pleased to be involved in nominating Dr. Phillips for this. I've known Kathryn since the early 2000s. And watching her, I know it's a long time, and watching her career evolve and grow ahead of me has consistently been an inspiration for my own career and my own work. Kathryn arrived at UCSF as a postdoctoral scholar in the 1980s after undergraduate studies in psychology at the University of Texas, Austin. And for a few years after that, she worked as a women's health counselor in San Antonio. And I think that was it in Texas, including on a military base as a civilian doing counseling on a military base. After that, she went on to get a master's from Harvard's Kennedy School of Government and actually received kind of honors from the military as a civilian that was involved in her pursuing her master's degree. And right after that, she, as far as I can tell, went straight from there to a PhD at Berkeley in the School of Public Health with a specialty of health economics. That then led her to UCSF. Now, you'll note that half of her educational institutions don't have a proper sports logo or mascot. So I think that might be one reason that she feels very much at home here at UCSF. Kathryn and I were introduced not long after I arrived at UCSF in the early 2000s. I think we were introduced by Richard Scheffler from UC Berkeley, who had been either one of her advisors or just knew her very well from those times. But he was an advisor, yeah. And she had gone where she'd gone to graduate school, and we were both health economists, so it made sense to introduce us to each other because there aren't that many of us here at UCSF. She then generously invited me, like barely knowing me at all, to get involved in a National Cancer Institute grant on the use of cancer screening and managed care, which was not her first NIH grant as a principal investigator. She had already completed a career award from NIH and then had landed her first R01 right after that. And then 1 year after that, got her second R01. So by that time, I can say I was just starting here. She was already an associate professor. She had not been here that many years. She had been accelerated to reach that title, much earlier than typical. And so you can see why I was completely blown away at her success at such an early stage of my career. And I think many of us observing her said, ooh, this is somebody who is moving fast and contributing a lot. I got to learn a lot from her study team meetings, and I got to observe many of the traits about Kathryn that make her such a powerhouse. She asks hard questions. She does not assume the easy answer is the right answer. She organizes her time, her work, and her teams incredibly well. And she stays on top of things to make sure that the milestones are met and the work is done and on time. Over her career, she has inspired many with all of these attributes, and she's also mentored many. Her CV has 2.5 pages of pre-doctoral mentees, more than half a page of postdoctoral mentees, and then about 3 pages of faculty mentees. So I think I counted about 60 mentees in there. Her CV lists 65 grants that have funded her work, some of which have been exceptionally large and complex. And as of late 2024, she was just shy of 200 journal publications. She has been identified in analyses of publications as one of the top 2% of cited researchers in the United States. Her work has had significant impact, I think, in 2 major areas, although I think I probably will mention more than 2. But I think the biggest 2 have been her leadership in research on how precision medicine is deployed in the real world. and how it should be deployed. She published one of the first studies on the potential effects of precision medicine in 2001, right? That was a long time ago, and was the first person awarded a National Cancer Institute program project grant to study the implications of precision medicine in 2008. Her lead article in a special issue of Health Affairs, for which she was the contributing editor, has been cited over 500 times. And with that NCI program award, she founded the UCSF Center for Translational and Policy Research on Precision Medicine, or TRANSPERS, which has had around two dozen grants since its founding and is the only center focusing on developing objective evidence on key policy issues related to precision medicine. This work is recognized not only for its scholarly innovation, but also for its importance to health policy. She's been an advisor to the FDA, the CDC, AHRQ, like the alphabet soup of government agencies, the President's Council of Advisors on Science and Technology, and the White House Office on Science and Technology Policy. The other area where she's had a particularly notable impact, which is newer to her, has been as the founding editor of Health Affairs Scholar. That is a new open access publication of the flagship health policy journal, Health Affairs, which is widely regarded as the most influential policy journal in the policy health space. I know a lot of people were interested in serving in that director role, and she was chosen as editor-in-chief. She is bringing her core traits to the work. She is constantly demanding that the articles published be rigorous, ask important questions, and she wants the work to be in the public service. So at 2 years, the journal had already been listed by PubMed, and already as a 2-year-old journal had an impact factor of 2.7. I suspect the 2025 impact factor is going to be rising exponentially. It's worth noting her contributions in other areas, including research on HIV home testing, which informed the FDA's decision to approve the first home collection HIV test, how financial incentives impact the use of various health services, and multiple aspects of cancer screening. She's had opportunities to engage internationally along the way. She had a Rockefeller Center Bellagio Residency Award for Global Scholars in 2016, which allowed her to spend time at Lake Como in Switzerland. And she received a Broker Foundation Scholar Award last summer to study open science publication in Geneva, Switzerland. I see a theme here about Switzerland. Kathryn's professional life is what most of us see of her, but she has many personal interests, and some of us have been fortunate enough to learn more about them. She is a mom. This is her son, Michael, in 2006, and more recently as a young adult. I had the pleasure of meeting him many years ago, and he has grown to be a wonderful young man. She also loves music. I ran into her on New Year's Eve at the Dawn Club in downtown for the early jazz set so we could all go to bed by 10 p.m. She loves to dance, so you can see why we're friends. She's also passionate about public service and engagement, not just in her UCSF work. She donates to organizations and recruits other people to join her at luncheons, events, and fundraisers. You can see her here with other powerhouses, including last year's faculty research lecturer, Rita Redberg. I could go on, but you're here to listen to her and not me. And we're all going to learn from Kathryn. She is ready to take your tough questions too, because she would expect you to be ready for hers, aimed at making all of our science better and our contributions towards a better healthcare system more significant. So congratulations, Kathryn.
Okay, she kind of gave my talk, but okay, searching for the Holy Grail, synthesizing science and policy. First, I have to thank many people, the nominators, the selection committee, my colleagues and mentors, some of whom are here today, family and friends, some of whom are here. I did hear from a lot of people today that they're home with this virus that's going around that I'm just getting over, but I think I'm going to make it through the talk. But they're at home in their pajamas watching on Zoom. But thank them as well as the people who are here today. And thank UCSF for being a fantastic place to work. Today's talk is more from my heart than it is from my head. Normally academics talk from their head. Today, I'm talking from my heart. So I'm going to start with a personal story, a date which will live in infamy, October the 1st, 2024. And by the way, you have to stay to the end of the talk to hear the conclusion to the story. But let me tell you the beginning of it. So I'm coming home on the plane from a National Academy of Medicine committee. And those of you who have served on these committees know that they tend to be really intense. And so I'm on the plane and I'm all jazzed up and we'd had this great meeting. And of course, I'm reading my email on the plane. So I open my email and there's a message from the clinic. And it said, call us as soon as possible. I said, darn. Because we all know what that means when they tell you to call to get your test results and they want you to call right away. And that's not the word I used at the time, but anyway. So that started a whirlwind for the past year. But I'm going to tell the story because I learned things as an individual, but I also learned a lot of things about turning science into policy. So at the end of the talk, I'm going to return to what I learned. Okay, things that we're going to think about, and I want you to be thinking about. How can we translate scientific evidence into policies that are effective, efficient, and equitable? How do we manage tension between we want it all for ourselves versus there is no free lunch? How do we facilitate innovation, but with the evidence to implement it appropriately? And then finally, how do we understand and integrate perspectives of all of the relevant stakeholders while remaining objective? So first of all, turning science into policy, a bit about how I got here. And some of this you've heard from Joanne. But it can be described as going from a Texas twang to DC governor speak, to Boston brogue, to California policy speak. I am born and raised Austin, Texas, the liberal oasis of Texas, I must say. I did go to DC to work for the federal government, as you heard. And I started thinking about, why do policies work or not work? And so I went to the Harvard Kennedy School of Government to try to learn, how can we actually study the implementation of policies and how they work and how to measure that? So I learned that there are all these really cool tools that we can use: decision analysis, meta-analysis, cost-effectiveness analysis. I'm like, wow, we have tools and ways to look at policies in a systematic way. But then I realized I really needed a PhD. So off I go to the promised land of California. Pulling my boots on and jumping in. See, I can still talk like a Texan. When I first got my bachelor's degree, I wanted to be a counseling psychologist because I thought I wanted to help people individually. But then I realized I wanted to help lots of people all at once. So I decided to instead go into health services research. And I moved from working in the bowels of government to applying rigorous methods for translating science into policy. Okay, science into policy, entering the field. So you heard that I went to UC Berkeley. I was the first graduate of a new program. I actually really didn't even know much about what the program really was because it was new, health services research. And I specialized in health economics. Did a postdoc at UCSF, got that 5-year career award, which really set me on my way. But I've always had the help of mentors who would tell me to pull my boots on and get to work. Many of you know Hal Luft. He used to be director of IHPS. And Hal used to always say, be first or be best. I quickly gave up trying to be best. So instead decided I could be first. So you'll hear that theme throughout this talk. And then Claire Brindis, who couldn't be with us today. Be strong in your convictions, but do it with a warm and gracious bear hug. And then finally, always with a sense of humility. Daniel Kahneman, who went on to earn a Nobel Prize, was teaching at Berkeley when I was there as a PhD student. So I ventured over into the psychology department, and it changed my life and my way of thinking about things. He's just this great, insightful thinker. And I love this quote of his: I have yet to meet a successful scientist who lacks the ability to exaggerate the importance of what he or she is doing. And I believe that someone who lacks a delusional sense of significance will wilt as an academic. So hopefully today I won't be too delusional, but take everything I say with a grain of salt. Okay, I'm going to cover some aha moments. These are some of my favorite research studies over the years. The first one, the takeaway is context, including policies, matter. Many of you may have heard of the behavioral model of utilization. It's one of the most commonly used frameworks, most highly cited in the past 50 years. And basically, this model says that healthcare service utilization is a function of predisposing, enabling, and need. Predisposing is things like demographics. Enabling is things like family resources. And need is things like perceived and evaluated illness. But I used this model and I thought, I think the model's missing something really important here, the context. Even though I was quite junior at the time, I had the guts, I guess maybe to call it, of approaching the model originators and saying, how about if we work on the model, a new model together? And lo and behold, they agreed. So we published a paper, Health Services Research, where the article's now been cited more than 1,000 times. And basically, we added two things. One is that the environment influences individuals. So healthcare system characteristics and the external environment, such as policies. We also added that providers and the interaction between providers and patients influences use of healthcare services. Aha, number two, evidence can influence policy. So back in 1994, you may remember that there was a big controversy over HIV testing. Specifically, should the FDA approve the first home access HIV test? On the one hand, you had people saying, this is the single most important weapon we can employ in the fight against AIDS. On the other hand, you have people saying the prospect of catastrophic effects from the lack of in-person counseling far outweighs the intended advantages. I said, aha, we need data. So I conducted the first empirical analysis of who said they would use a home access HIV test using NIH data. This paper was published in the New England Journal of Medicine. And as you heard from Joanne, it was cited in the FDA decision to approve home access tests. The other really cool thing about this is the only time I've ever had a paper reviewed and published in 2 weeks. Wow, it was so exciting. Basically, we found that those most in need of knowing their HIV status were those who were most likely to state they would use these tests. People who were male, younger, non-white, less educated, lower income, had risk factors, had donated blood simply to be HIV tested, or had not been tested because they did not know where to go. Okay, continuing the journey. It's always been about turning science into policy. I did start with my career working on HIV screening, then went to cancer screening, and then precision medicine and beyond. So I took a leap, creating a research agenda and center on precision medicine. You see here what a senior faculty member, who will remain anonymous, said to me. Why would you change your research focus to genetic testing and precision medicine? It's too early. It won't go anywhere. And why should we examine implementation and policies when it's the basic science that's important here? Then I approached a basic scientist about working with me on my first study in this area. He said, and he may be on Zoom if you are. Oh, you remain anonymous. So he said, I want to collaborate with you on this paper, but I don't understand your methods or your terminology. Are you sure you know what you're doing? Okay. Whoa, I'm missing a slide. Oh, no, aha, number 3. So this is the study that came out of that. And the takeaway is discovery science on precision medicine benefits from the assessment of policy implications. So this particular study was focused on adverse drug reactions. And this was back in 2001. And there was a lot of concern about ADRs being a significant cause of morbidity and mortality. And emerging evidence was finding that these ADRs may be avoided through individualization of drug therapies based on genetic information, what we call pharmacogenomics. And here's one example that is quite a story. A 13-day-old breastfed baby died from morphine overdose. Well, how did that happen? It's because mothers were taking Tylenol with codeine. And if you're an ultra-rapid metabolizer of what we call CYP2D6, which is a genetic variation, you can't metabolize the drug, and therefore their breast milk contained morphine. So they accidentally killed their newborns because they didn't know that they were ultra-rapid metabolizers. And if they had gotten testing, they could have avoided it. But we knew that there was no systematic evidence linking ADRs with genetic variation. So I put together this collaboration. We had a PharmD, we had a basic scientist, and we had students. So it was quite a motley group, but we did get it published in JAMA. It's been widely disseminated even among basic scientists. This was 2001. Basically, what we did is we statistically linked systematic reviews of ADRs and genetic variability. The findings, genetics were a significant cause of ADRs. For the tech people in the room, 59% of drugs cited in ADR studies were metabolized by at least one enzyme with a variant allele known to cause poor metabolism. So the conclusion was, genetic testing may result in a clinically important reduction in adverse outcomes. And this study then was the foundation for further research on clinical, societal, and economics of pharmacogenomics. It's been cited in 46 policy documents globally. So, aha, number 4. As you heard, I did start the TRANSPERS Center in 2008 by leveraging PO1 and RO1 funding. It is still going, and we have a number of TRANSPERS people in the room who are all part of this. 200 publications, 8,000 citations, 23 grants, 18 million, continuous NIH funding since the beginning, 400 citations in policy documents across 31 countries, collaboration across 17 countries, and 75 trainees. Phew, it's kept us busy. Basically, TRANSPERS says the success of precision medicine requires a focus on implementation challenges. So we focus on 3 major areas: coverage and reimbursement, economic value, and stakeholder perspectives. And the goal is to have adoption that is appropriate, efficient, and equitable. One that makes us unique is that we work across all the different stakeholders. We don't actually work with these people. We don't take their perspectives, but we consider their perspectives because all of these different stakeholders play an important role. So we're the objective, evidence-based intermediary to pull all this together into a cohesive whole. We've had widely published studies across respected diverse journals, ranging from more general journals to specific ones on genetics, a lot in cancer journals. And Joanne mentioned this one already. That was particularly fun to do because it's been cited more than 600 times and has an all metric score 300 plus. Okay, now I'm going to do one deep dive into our research to try to give you a flavor of the kind of work that we do. So, payer decision-making and insurance coverage. Understanding coverage requires multiple perspectives and multiple approaches. So, three main approaches. First of all, we do empirical analyses of the coverage policies themselves. What do insurers state in writing that their policies are? Then we do qualitative analyses of how payers make decisions. What do they say they consider? What kind of evidence do they say they're interested in? How do they explain their decisions? So that's all done with qualitative research because you can never, ever get that information from a quantitative survey. And then finally, because it's so important to understand what happens on the ground, we do descriptive analyses of how clinicians and patients respond to coverage at the point of care. So, aha, number 5, thoughts from decades of research on payer decision-making and insurance coverage. So, first of all, pop quiz. As a teacher, don't you love to be able to just say, pop quiz, get out that piece of paper, put away your phone. I haven't gotten to do that in a while, but it was always fun to do it. So we're doing a pop quiz here in the room. Raise your hand if you want, but true or false? Are payers responsible for our system's failures? True? False? A lot of them don't know. Okay. Can where you get care, as in where you live and where, for example, your lab test is done, determine whether Medicare covers your services or not? Is that true? Oh, you guys are too smart. False. Okay. See, that's one I didn't know myself until recently. Can we rely on professional society guidelines to determine what care should be covered by insurers? True? False. Oh, okay. We've got a lot of false ones there. And then finally, prevention saves money. True? Oh, no. Oh, my God. I gotta. Okay. Now, I may be a dismal economist. I'm always running around saying, there is no free lunch. But Mick Jagger studied economics and look how he turned out. Prevention does not save money in general. We don't provide any type of care in order to save money. We're hoping it provides better health at higher cost. There are very few healthcare interventions that actually save money. In the area of prevention, the only ones that consistently do are, can anyone take a guess? Vaccines. Vaccines. The one thing that can save money, and look what's happening to vaccines these days. I won't go there. But the others, you're right. Payers are part of the problem, but not the entire problem. There are a lot of local coverage decisions by Medicare. There's 16 MACs that make decisions. These local coverage decisions are much more common than national coverage decisions. And there can be a lot of variation across these MACs in terms of what they will cover or not. So I always thought Medicare was a national program. Well, it's not really. And then professional society guidelines are really important, but They actually vary quite a bit. So now I'm going to talk a bit about research on payer decision-making and insurance coverage. I am learning from the horse's mouth. Payers, essential, fascinating, listen and learn straight from the horse's mouth. As I mentioned, we've been doing this qualitative work with payers. We have a payer research board that we set up in 2007. It has all of the largest healthcare plans in the US represented on this board. These are senior executives who give their time. We do not pay these people. And we are totally objective. We only do peer-reviewed research with them. But I've learned so much by actually listening to payers. So I found it really fascinating. So a few things about payers. Payers are not the bad guys. They're not bad guys or good guys. But it's important to understand that payers have mandates and constraints. They are not out to deny care and hurt patients. They're trying to deal with the context within which they must operate. When you've seen one payer, you've seen one payer. There's a wide variation across payers. I already talked about Medicare, Medicaid, 50 different states. So it depends on where you live. And even among private commercial payers, there's a lot of variation in how they think about coverage, what kind of evidence they use, how they make decisions. You may not know when you've seen a payer. You've probably heard of PBMs, pharmaceutical benefit managers. Well, in the diagnostics world, we have lab benefit managers. And these actually draft a lot of these coverage policies. And they're just like PBMs, they're hidden. People don't really know what they're doing, how they do it, but they play an important role. Same with self-insured employers, who we often don't think about, but they determine benefit packages. A few more thoughts. Payers do use evidence and guidelines in their decisions, but evidence interpretation and guidelines themselves vary, and they always will vary. I often hear, well, we're just going to make all the guidelines the same. Can't everyone just get together and decide on a guideline? It doesn't work that way, because the guidelines organizations all have different mandates, constraints, methods, etc. Payers have a mandate to cover services medically necessary and non-experimental. In other words, they're not supposed to be covering anything that might work or that a patient or clinician may value. But we have seen, particularly over the years, that payers can be flexible and use flexible approaches. For example, using real-world evidence for coverage decisions versus relying only on RCTs. Payers must deal with increasing complexity. For example, whole genome sequence tests. That's a really hard one for payers to figure out how to evaluate and then make coverage decisions. Now we're seeing new AI approaches to diagnosis. And once again, the complexity of what payers have to try to figure out is really challenging. So now I have some recommendations. These may be controversial. We need to understand how and why payers make decisions. So I've been talking about this, that we fill this gap as an objective synthesizer. We don't take the position of payers, but we listen to payers and then turn that into peer-reviewed publications. But this is not the type of thing that NIH typically supports. We have been able to get it supported, but I would love to see this type of work continue. We need assessment of relative costs versus benefits by objective technology assessment groups. You may have heard of the group called ICER. They play a really critical role, and payers listen to what they're doing and evaluating. They evaluate mainly drugs, though, as opposed to diagnostics or devices. and they work on determining a fair price. And I am a member of one of their review committees. But I think we need a new Office of Technology Assessment. Some of you may remember that we used to have one in the US. That went away. But it seems to me that would be very helpful. Evidence needs to be developed early. With our work, we always try to be ahead of the curve, because otherwise what happens is that drugs and tests enter care before the coverage policies are developed. And then these become standard of care, even if the harms outweigh the benefits. And it gets too late for payers to say, oh, we're not actually going to cover that because the harms outweigh the benefits. So early evidence for use in making coverage decisions. I have a few more. Policies need to be based on evidence, not aspirations or ideology. We recently did a study published in JAMA that looked at this idea of using state legislation mandating coverage of specific services, in this case, biomarker test, which seemed like a good idea, right? You know, we have this intervention and we want better access for people. Let's mandate that payers cover it. But when we looked under the hood, we could see that there were a lot of unintended implications of doing it. So it may not actually provide greater access as intended. So it's a good example of where we may have a good idea that sounds good and everyone jumps on the bandwagon, but when you actually look at it, it's not such a great idea. And then finally, it's all connected. Coverage policies emerge from a complex and convoluted context with incentives, regulations, legislation. But the more we can look at and consider that whole context, the more policies will make sense. Now I'm on to what's next. And I'm going to talk about some research and service. Mentoring is the other thing I'm very involved with now, but I'm not going to cover that today. Okay, I'm still working in precision medicine. There's a tsunami of emerging tests. So this work on policy implications of it is essential but challenging. So let me give you a few examples. Multi-cancer screening test. These are simple tests using blood, or I should say simple blood draws. They're not simple tests. In some cases, they can screen 50 different cancers, including many cancers that currently have no screening test. So it's like, wow, does that sound like a great idea? Well, there are a lot of things to consider. They're quite controversial. One reason being the risk of overscreening and finding things that don't mean anything or that you can't do anything about. But obviously, patients are like, oh, I want this. I want this. It sounds great. So these tests are on the market, currently mostly out of pocket. So only if you have money, can you get these tests. So we wrote this paper on how do we consider and develop the needed evidence in order for payers to make appropriate decisions. Next one is one of my favorites these days, Alzheimer's test. So we published a study looking at payer coverage considerations. We all know that there's a huge need to be able to diagnose Alzheimer's early. That's when the new drugs might work. People want to know if they might get Alzheimer's. But just as with Em said, this is a very controversial area. The existing methods we have for diagnosing Alzheimer's are not particularly good. They're costly and invasive, such as PET and CSF. So people are developing these new tests based on blood draws. Once again, they are on the market. Insurers are not yet covering them in general. So we have self-pay. So once again, if you've got the money, you can get it, but should you be getting it? And what are you going to do with the information when you get it? And how are payers going to make a decision on whether they should cover this and when? And then finally, since we always try to get involved in new areas, precision nutrition. We all know there's big interest these days in nutrition interventions, such as the obesity drugs, GLP-1s, the MAHA movement. But just as with these other areas, we need precision medicine. We need to be able to target these interventions to the people that will most benefit and who won't be harmed, as opposed to assuming one size fits all. And once again, there are lots of tests out there on the market. They're largely direct to consumer. They're not only self-pay, but you can just get them when you want. So we have this chaotic situation where we're going to need more evidence. Now I'm going to talk about giving back, using committee service to further science into policy. So rubber chicken dinners, some of you may remember that phrase, because if you go to all these meetings, especially government ones, the food's not very good, right? It's always rubber chicken. So over the years, I've eaten a lot of rubber chicken. Starting with the FDA, helping the FDA develop regulatory frameworks for precision medicine. This is back when they were first even thinking about it. I knew Mark McClellan, who was the FDA commissioner at the time, and he asked me to help out. So I spent a lot of time out in the middle of this field, which is where the FDA offices are, eating rubber chicken, but it was quite interesting. Then for a number of years, I worked with Genome Canada. Genome Canada is an organization that coordinates and develops genomic research across the entire country of Canada. And for a while, I served on their board of directors and learned all about genomics, and including food, because you do genomics in food as well. And a lot of that is in Canada. Then, as I mentioned, ICER, Advancing Use of Evidence to Improve Healthcare Affordability and Access. And I've been involved with them since 2020. More giving back, and I call this plane the, instead of rubber chicken circuit, it's the San Francisco to DC circuit, where we always are seeing colleagues on that plane. Now, I don't like it when it's only 6 in the morning and I haven't even combed my hair and there's a colleague, but we all fly back and forth between San Francisco and DC a lot. So I've been spending time contributing at the national level to various NAM committees. There's a NAM roundtable on genomics, which is really interesting because it's mainly non-academics. It's people from, for example, professional societies. I just completed service on a consensus committee on aligning investments and innovations for therapeutic development, disease burden, and unmet needs. I was just named to MedCAC, and this is the first time I've ever had to sign on a piece of paper that to help me God, something I'm going to protect the Constitution or something to help me God. And I actually had to get that notarized. That's the government for you. But I haven't started actually doing anything yet. And then I've always been really interested in translating science into policy in the real world. I see Reg Kelly there, who's someone I have really watched what he does in that arena. So I've worked with a number of companies over the years, mainly startup, venture capitalists, and then most recently QB3 Baker Labs. My third area of service, as you heard from Joanne, is scientific publication. This is relatively new for me, but we all know scientific publication is extremely important, right? It really drives what we can do and what gets disseminated and what gets paid attention to. So I did take on this opportunity and challenge of becoming editor-in-chief of Health Affairs Scholar It's the first spinoff from Health Affairs in its 40-year history. And it was a startup because it was de novo, developed the focus strategy and the editorial team. I call this the what? Whoa, wow, we experience. It's one of those interesting things I've done, but one of the hardest things I've done. Every single day, there's something new. Some authors complaining about something, or, it's always something. And they always come to me and somehow they find my email and we don't like what you said about our paper. But anyway, it's important work, so I'm happy to do it. Okay, summing up. Lessons from the School of Hard Knocks. These boots have walked through mud, dust, and hard times, but they're still standing. I have 4 lessons. Complex to simple can be as useful as simple to complex. When I was a graduate student, the big thing was, oh, how can we make something really complicated with formulas and econometrics and statistics, and let's confuse everybody with this great work we're doing. Well, I did that, but now I'm much more interested in complex to simple. I like to take complex science and really dumb it down so that we can actually use it. Crunching data is good, but synthesizing policy implications of data is more fun. So I did my data crunching when I was junior, but these days, no data crunching. I just like to talk about what does it all mean. Think big, think forward. You've already heard how I gave up being best, so instead I try to be first. So always scanning the horizon. And then finally, I've learned no one else knows what they're doing either. I worried for a long time, I don't know what I'm doing. I realized no one knows what they're doing, but we do it anyway, right? So don't feel bad if you don't know what you're doing. Okay, back to the final aha moment. There's nothing like learning by doing. So I did get a diagnosis on October 1st, 2024. It required extensive care. But 1 year later, I'm back in my boots and I'm almost back to normal. What did I learn? Certainly my experience as a patient isn't unique, but I did learn a lot about turning science into policy. When the system works, it's fantastic with the best clinicians you would ever want. But there are many opportunities to improve. Personally, I feel more fragile, but also stronger and more determined. So that's the good news. So insight number 1, choosing high value care at the right price goes out the window. Another bill, another test. I need this service, but not covered by insurance. I'll pay. I don't care anymore. I can't deal with it. Patients get totally overwhelmed. I used to be a really careful shopper. The billing department would see me coming and go, oh my God, not her again. Because I'd want to know, how much is this going to cost? Do I really need this? What's the marginal value? What is the evidence? But I quickly had to totally give that up and just bill. Because it became impossible to assess the value of what I was getting and impossible to actually try to be more systematic about it. And I quickly hit my out-of-pocket maximum. So at that point, it was like, it's free. Oh, they want to give me a prescription I may not use. Oh, that's fine. I'll take that. Insight number 2. Translating evidence can't happen if the evidence isn't there. There's no good evidence for determining if treatment provides marginal benefit or assessing future risks. That's what I heard from a clinician. Oh. And then me saying, well, I finished this initial treatment, but now you tell me this is only the beginning and you want me to do X, Y, Z. So I've always wanted to know the evidence behind my provider's recommendations. But I quickly found that we have a lot of gaps in the evidence. For example, things like risk prediction models of treatment pathways. So that I couldn't actually make a decision of what I wanted to do because the evidence wasn't there. And so therefore trying to decide, do I want this onerous treatment because it might improve my outcomes, became really difficult. And also that patients tend to be told what's going to happen at the beginning. And then you're through the main thing and it's like, oh, good. I'm out of the woods, I'm done. It's like, oh no, we need to do this test. Oh, you had this side effect, we're going to treat it with this. And oh, that's going to give you more side effects. And then we're going to do this MRI, we're going to do this scan. So it's this long tail that patients don't often realize that they are going to have to deal with. Incentives matter, and they are often inherently misaligned. We cannot pretend that we can fully meet both individual preferences and societal needs. I felt really hard or had challenges with this one because on the one hand, as a patient, I realized I want anything that might help me. But then I put on my economist hat and go, oh, it doesn't provide value at the population level. I really shouldn't get this. So it was this tension between the two. And as a society, we tend to pretend that tension doesn't exist. Oh, we can give everybody everything they might want. Well, we can't. So we just don't like to face those decisions head on, here in the United States, at least. And then finally, inequities are real and can be devastating for those who don't have knowledge or resources. I feel guilty that I'm leveraging my connections. But I had to. I couldn't get into care at the place I wanted to, first of all. And then to get the clinician that I wanted, I used my connections. But I felt bad about that. It's like, oh, is this fair? Because other people don't have those connections. And I had to learn to be very proactive about my care. Let me give you one example. So I arrived at the clinic for a 6-hour treatment that had been planned well in advance. I get a call as I'm walking in the door and they said, we're sorry, but your pre-authorization wasn't approved. You can either sign this piece of paper that says you'll pay $26,000 out of pocket if the insurers don't cover it, or you can reschedule. I said, no, I'm not doing either of those. I want to speak to a supervisor. So long story short is that I did get my care that day. But a lot of people wouldn't know that they can do that. They wouldn't know that they can say no. Or maybe they don't speak good English, or they just don't understand the system. So again, I realized how there are a lot of people who really have to deal with a lot when they're getting care. So gratitude for opportunities to put on my boots every day and pursue my passions. For everyone who helped me along the way. For what is a great university to work at. And for what is a great healthcare system, despite its flaws. Thank you very much. And we do Q&A. Do I do it or?
Hi, my name is Juan Carlos. Oh, thank you. Hi, my name is Juan Carlos. I'm a second-year scholar at the National Clinician Scholars Program. Here with majority of my colleagues actually are right here. I very much appreciated your lecture. It touched upon a lot of big sort of concepts and ideas that I think a lot of my co-fellows and I think about every day, especially in this stage in our career. Like, how do we pursue our values with it in the intersection of like policy, healthcare, and economics. And one question was, early on in your talk, you were recognizing how we don't save money with a lot of like providing good healthcare, basically. And I'm curious from your career and sort of policy mindset, how would you approach making that shift of we need to stop tying money and economic drivers with healthcare, but maybe, I don't know, is there kind of a way where we can go towards that sort of universal healthcare, or kind of what has been your thought processes through these years?
Yeah, first of all, about prevention not saving money. I mean, think about it, that if we really, all we cared about was saving money, we would tell everyone to smoke cigarettes because they would die early and they would save money, right? So you can see how kind of absurd that idea is, but it's locked into people's heads, that and you hear it all the time in the political realm of, oh, we're going to save money by doing this. But what a lot of countries do, because you can't get around dealing with money, it's just the way it is if you have an overall budget that you're operating under and you have to make choices within that budget, as opposed in the US, we don't have that overall budget or this comprehensive, cohesive national system. So, you push on the balloon here and it pops out over there. And so it's really hard to pursue a value-driven system. But I'm glad to hear that you're working in that area, and we need young people like you to work in that area. Bob? The mic is coming to me. Is it on? No. St. Kitts got one.
Here's another one. This one might be.
Oh.
Yeah, the question is, I'm Bob Hyatt. Happy to be one of your nominators as well. And happy to have watched your career over the years. You've been tremendously successful with publication. And my question is, how important has publication been to influencing policy? There's not a direct line between publishing in the New England Journal and getting a guideline changed. So I'd be curious to know what you think.
Yeah, that's a really interesting question. And I've always been someone who wanted to provide the evidence and the publications, but I don't directly work in policy advocacy or get involved. But many of you knew Drummond Rennie, who was here at IHPS. And he used to always say, he was deputy editor of JAMA. He used to always say, if it's not published, it doesn't exist. So you've got to get things out there in order to be used. But then whether they are actually used, that's kind of a whole other question. Yeah. Sanket?
Oh, great. Thanks, Kathryn. Thanks for such a beautiful presentation and sharing personal and professional stories and really incredible journey. I want to ask you about the multi-cancer early detection tests and these early tests, these tests for early Alzheimer's disease. And in particular, it sounds like, I know for MSIN, it sounds like for the Alzheimer's disease tests that they're not FDA approved. And I guess I wonder how we can be in a healthcare system where if you can afford $1,000 multi-cancer early detection test, then you can get it because of, I wonder if you might talk to loopholes. And then also what strikes me as a concern is, so if you have a positive multi-cancer early detection test, then you're going to get a PET CT scan and a large workup, maybe some MRIs, biopsies, et cetera. But all of that is going to be on the health insurance companies, for lack of a better term, tab, which we are all paying into. So it seems even more perverse than just, well, I can go out to an expensive dinner that a lot of people might not be able to. Well, I can go and buy this $1,000 test and then might even take more from the system. And I wonder if that might happen.
Yeah, I mean, that is a really important question that is emerging as a policy question. And in fact, we have a paper that's under second review that addresses just that, where we did a study with our payer research board to see what they felt about follow-up testing after MCED. Huge variation. Some say, well, I have to cover it. Even if the original test was not covered, if they then need a mammogram or whatever, we would just cover it. Others say, no, if the original test was not covered, we have no obligation to cover any follow-up. And then there was a whole group of payers that said, we really don't know what we're covering because they can't tell that an MCED test precipitated the follow-up testing. But it's a huge problem because people think, oh, MCED testing, we'll just all get it. But there's a huge cost in all this follow-up. And if you're looking at 50 different cancers, you know, the chances of finding anything that's actually significant is quite low. So, but it generates all of these imagings and other stuff you need that can have harm. So it's a really huge issue. Absolutely.
Yeah. Hi, Kathryn. Yeah, thank you so much for your presentation. It was really fun and wonderful, and congratulations on all your successes. My question was, I thought it was interesting when you said that we need to understand payers' decision-making process. And I'm curious what your thoughts are about trying to understand a process where it's opaque, it's not clear. I mean, I'm working on a project with Emily. We're looking at some payers' reimbursement for pharmacogenetics. We send a bill and we're getting like $6. Like, okay, you know, how do they come up with these numbers when it's so challenging to understand that? And I'm curious what your thoughts are on that.
Yeah, well, you're right. It is opaque, and that's partly by design, right? Because payers, it's like they know it when they see it as to whether they want to cover it. And Reg will appreciate this. And the industry folks would always ask me, well, why can't the payers just tell us what they'll cover? They just need to tell us they want this evidence. We give them that evidence, they cover it. And that's not the way it works. They're holding their cards close to, we want to see the evidence and then we're going to consider it. And that's not going to change. So that's just the way it is. You're not going to be able to make that more transparent or necessarily more systematic. Like I said, payers vary a lot.
Yeah, I thought your point that, you know, if you've seen one payer, you've only seen one payer. I think that's spot on for sure on that. But it makes the process far more challenging and painful. And it's there's just that lack of transparency.
And it's frustrating, of course, for
very
patients and clinicians. Yeah.
Very frustrating.
Yeah.
Thank you.
Good point. This woman here in the middle would like a mic. And then I think Michael has his hand up.
Hi, my name is Samine. I'm a second-year NCSP fellow, family medicine trained. Thank you so much for the presentation. What you talked about, particularly where your career is now, thinking about how to make policy relevant impact is something that is what I definitely want to do as a fledgling person in this space. And going to the earlier point brought up by this gentleman here, is one of the things, like, you know, being especially in a fellowship where everyone is talking about getting your first K award and these sort of topics. And then it's more about like generating evidence and generating these articles. And then as a second thought, it's like, okay, now once you've made something, how can we think about who it's relevant to and impact?
Mhm.
It sounds like the group that you've made, and I apologize, I forget the name, but the pair group.
ICER, maybe.
No, the other one.
Oh, Para Research Board.
Yeah, that one. Like with either that group, which is that's specific to pairs, but even other ones that are like perhaps at the state or local or county level, whatever it is. Like, is there a pipeline that exists at all in this country of people who are early career, you know, looking to think about how to do their K awards, but instead of it like I'm trying to think of how to articulate this, but instead of bottom up, top down, like there's a consortium which talks about these relevant policy topics so that you can develop your award with those topics in mind, coming from the actual people at the front lines of policy, so that instead of thinking about it after the fact, you are thinking about it from the inception of your career. Like, does that make sense?
Yeah, I mean, I think that just what you're saying is, how do you make sure your research, even at the early career stage, is going to be relevant? And for example, my career, I started as a data cruncher and developed, technical skills in order to get those initial awards. It was only when I became more senior that I could write commentaries and someone might publish them. But what I've always applied is the question of, is it important? And so I'm always asking, is this work important? Does it mean anything? And if not, then I don't do it. And so if you apply that litmus test to whatever you're doing, that might help you as an early career person. I think Michael was next, and then this woman in the back. Oh, okay.
I just listening to you today, I just realized that we've worked together in some capacity for almost 20 years now.
Oh my God.
I know a number that I was not expecting in my head. But I want to ask you the tough question today. That I never felt like I had the opportunity before to ask is, what do you consider your greatest achievement?
That I'm still standing. I mean, to me, the TRANSPERS Center is something I'm particularly proud of because I just dreamed it up. I never got any money from the university to set this up, but no one ever told me I couldn't do it. So I'm like, oh, I'm going to set up a center. And lo and behold, it still exists. People know it around the world, even though it's really kind of small. Its profile and presence is known. So it was like creating a startup. So I guess I'm an entrepreneur at heart, and that and all the people I work with, like you, I'm grateful, and that was a great accomplishment that we survived 20 years. Okay.
Liz, I think there's a question on Zoom you want to ask.
Yeah, I have two questions so far on Zoom. One is similar to the previous one from Richard Phillips.
Liz?
Yes?
Yeah.
Wait, can you hear
someone
me?
else had their hand up while we were figuring that one out. Yeah.
Joey, you can't hear me?
Oh, and Reg has his hand up.
Joey,
And,
no one
and this
hear me?
woman in the sweater. Oh, here comes the Zoom.
Wait, can you hear me or not?
Okay, so first question on Zoom is, what single achievement, if you can pick one, do you feel was most impactful in people's lives?
People-wise?
On people's lives.
On people's lives. Oh, well, I mean, and there I'd say, the home HIV test work to me was extremely gratifying. But as to how many lives it saved, I don't know. But definitely it ended up with a good policy. And so that was very rewarding.
Second question from Zoom is, the FDA is approving new molecular entities each year, but those designated personalized medicines never exceeded much 35%, contrary to early expectations. Any thoughts on what is holding it back?
Oh, well, that'd be a lecture, I think, in itself. But precision medicine has really moved ahead in some areas, like oncology. I mean, we used to treat breast cancer as if it was one breast cancer, and now we know there are all these different kinds of breast cancers. We have all these different drugs that treat them differently, and it's been a huge advancement. In other areas, we haven't seen as much. For example, the precision nutrition that I mentioned is an area where I think we could have more growth and more work. Reg?
So we've just been teaching a course on expanding the health span. And of course, one of the standard things everyone says is you've got to eat better and, and you have to get more exercise. But it seems the thing which is most explicit about expanding the health span is getting rich, right? When you look at the difference in lifespan between the rich and the poor in the country, it's about 10 years. It's about 4 years in Norway. Do you see this as just something we have to live with in America?
Oh, well, I mean, we're always working to try to not have that, right? But the fact is, people have money and they will pay for what they want, and they have resources of all kinds that some people don't have. And that's just the way I think the US works. So, but you're absolutely right. That's true. This woman here.
Hi, I'm Lindsay. I am also an NCSP scholar and a nurse PhD from UCSF. I appreciated your point bringing up that policies need to be evidence-based and rather than based off of ideologies. I come from the home healthcare space for children with complex care needs. I think a lot of the policies we think of when wanting to provide care tends to be very ideological, but at the end of the day, like you said, we can't give cares for everyone. I think when we're early investigators, what are your recommendations for us thinking about those policies that may actually be effective in providing that care access to as many as we can, making it equitable, whether those are tools or support resources that you think of to make sure this is a good idea for actually providing that access?
What are tools and resources? Oh, wow. Oh, that's a tough one. I mean, I would think it's the same idea of looking at the evidence and building the evidence base to look at these differences and why they exist and what's the best way to address them. So it's just back to evidence. This gentleman, that gentleman.
Hi, my name is Jake, and I'm a PhD student in the Pharmaceutical Sciences and Pharmacogenomics program here, UCSF. And so I'm coming at this more from the basic science side of things, developing these diagnostic test biomarkers. What's the best way for an early career person like me, continuing on the previous questions, to make sure that the basic science research that I'm doing or my colleagues will be doing will translate into meaningful impact and potentially be implemented?
Oh, I love that one. Come see us at TRANSPERS, because I mean, that is what we do. We work with basic scientists and clinical scientists because we need to all work together in order to ensure that happens. So come and see us.
Will do. Thank you.
Hi, I'm Rahel. I'm also a fellow in the National Clinician Scholars Program. Thank you so much for your talk. I'm curious about whether your experiences as a patient have informed some of the future work you hope to do, and what kind of implementation science research do you think we need in order to help ensure more equitable access to care for patients? I'm thinking about the anecdotes you shared in terms of how complicated it is to navigate this insurance system, and how it's those of us who have all of this privilege who are able to get the care we need on time, and what kind of research would you like to see in that area?
Yeah, oh, that's a good one. I think of two things. One is this whole push towards having patient navigators and this interface between clinicians and patients to help guide the patient. I think there's a lot that can be done there. And even though I said it's hard to determine prices and assess value, I think we need more work in that area. I'm a big fan of price transparency. There have been policies in recent years to try to increase price transparency, but we need to make that more usable. And then we need to actually have people have skin in the game, as in you have to shop because there are limited resources. But of course we have to figure out when people can really shop appropriately and when they can't. But certainly some things you can shop for. And I think that's one way to address some of these issues.
Hey, Kathryn, wonderful talk. And we've worked together since the late 90s. Listen, one question I have, and I know as a behavioral scientist in some areas, is that this anti-science fervor and the politicization of medicine and science. And, you know, have you given any thought in terms of what may be some approaches strategically to look at some of these sort of behavioral patterns in the politics of medicine? And you were in DC, so you know the muck that goes on out there.
Yeah. You're right. I mean, science is taking a big hit these days with all the distrust in science. And I don't have an easy solution for that. But I think it's going to be partly how we develop science and how we then communicate it to people in ways that they can then understand it and assimilate it and believe it. So I think there were a lot of lessons learned from the COVID experience of how we could have done things differently and therefore decrease this distrust in science that emerged. But it's a tough one.
So we have another question on Zoom. Coverage with evidence development in Medicare is now 20 years old. What impact has that had in terms of Medicare coverage policies and other evidence for decision makers?
For those who don't know, coverage with evidence development is a way that Medicare lets new products get on the market and get coverage while they're still doing studies. And we did a study on this, and others have too, that it showed that the problem is they often don't do the studies, or they do the studies, they don't withdraw the product. So it's a great idea to get things out there to help patients as soon as we can, because that's what everyone wants. So this tentative coverage is one of those things that sounds good, but then you actually have to close the loop. You have to get the evidence and you have to make a decision. Sometimes you have to withdraw. Payers, though, hate to withdraw anything, right? Once it's there, people are getting it, they want it. It's really hard to take it back.
Another question on Zoom is, you've been able to skillfully both accept the reality of private insurance operations, as opaque and unjust as it is, while also continuing to interrogate and expose its inconsistencies and ways in which they fail us. Do you see price transparency as a first step to holding companies accountable? How does price transparency impact those who have no choice but to pay?
Yeah. Ooh, that's another easy one, right? Not. Well, price transparency has benefits and limitations in and of itself. Gosh, how do I even answer that? Tell me the last part of the question again. How do we hold people accountable?
Yeah, how does price transparency impact those who have no choice but to pay and holding companies accountable?
Yeah, and then that's kind of the two issues. One is that price transparency, as I noted, sometimes doesn't help patients at all because they can't deal with the complexity of it. Just because we have price transparency won't take away the variation we see in payers necessarily. I mean, we all know there's huge variation in the prices that payers charge and that the reimbursements they get, huge. And many studies have shown that. And that's not going to go away because payers are different, right? Payers have different populations they're accountable to, or different patient base, or different mandates to follow. So it's not really going to be a silver bullet, but it just seems promising to me. And we are about ready for reception. I wouldn't want to get in the way of that. Is there one more question? Okay, Keith. You've been holding out for the last word.
That's not true. So as you know, Kathryn, I've been coming at precision medicine from kind of the opposite direction, and it's been just a pleasure and an honor to actually be working with you to kind of bring a lot of this stuff together. So congratulations for all of that, and thank you for your work. I wanted to ask about you said at the beginning that payers aren't the good guys or the bad guys, and in thinking about costs and equity. Mm-hmm. One of the dilemmas that we're really in the middle of right now is that we just don't know who is going to be helped by a given test, by a given drug, and who is not. And so on the one hand, you say, well, cover everybody, give everybody all the tests. And of course, that drives costs through the roof, which is really kind of where we are right now. As precision medicine moves forward, and we better understand who's going to be helped by a given drug, who's going to be helped by a given test, then payers will be able to say, no, we're not going to cover that for you because it's not going to do any good. That's good, right? And in a sense, it should drive costs down. So having that information should be useful for payers and allow them, in a sense, to become the good guys, right? But now you can kind of extend the argument and say, because we're moving toward an environment where everybody's genome is going to be sequenced, and there's going to be information in those sequences that will be more and more affirmative in being able to say you're going to get this disease, right? And so while that information should be private, we all know that information is not going to stay private. It just doesn't.
Right.
How do we, as we move into that world, how do we ensure or assure that payers will be responsible with information that they could misuse? I mean, they're in a business.
Yeah.
Right. And so what kind of, I don't know, is it regulations or values do we set as a society that allow, that moves as we move into this world, we move into it with the kinds of responsible behavior that will not make really horrible inequities moving forward.
Yeah. Oh, wow. That's a great question to end with. As you probably know, the ACA covers pre-existing conditions, and that was a huge change in policy because it used to be insurers could deny coverage if you already had a condition. So moving to that where they can't deny coverage because of pre-existing conditions is very related to what you're talking about. But you're absolutely right. This idea of, well, we're going to sequence all newborns, which a lot of people are now pushing for. And then you might have knowledge of what might happen to somebody 10, 20, 30, 40 years from now. One thing to keep in mind is, what does insurance actually mean? Insurance is meant for non-predictable events, right? Like a car accident, car insurance, right? It's meant to pay for things that can't be predicted. But if you have this scenario where a newborn knows that they have a higher risk of getting XYZ, what do you do about that? It's really kind of a fundamental shift. But I totally agree with you that the idea behind precision medicine of targeting things to people that will most benefit, I mean, that is just fundamentally, paradigm shifting. And someone earlier asked, well, why has it been slow in some ways to be implemented? And there are a lot of reasons for that. But you see some movement over time. And I was just listening to Laura Esselman talk about her wisdom trial, if any of you are familiar with that, where she's been working for 20 years to try to see if we can't target mammography. And I don't know if they've released the results publicly yet, but there's some encouraging movement towards the getting away from the idea of everybody should get X. But it's a huge paradigm shift. We're used to everyone over a certain age gets a mammogram. That's just kind of the way it is. So to change people's minds to, certain people need it, certain people don't need it. I think we have to get there, but it's just going to take a long time. Okay, thank you very much.